I'm just going to read my study guide for Chapter 24, Pneumonia, from Egan's. The Introduction to Pneumonia. Overview of pneumonia. Pneumonia is defined as an acute systemic immune response to microorganisms in the alveolar space, challenging the previous notion that lungs are sterile. The lung microbe consists of diverse bacteria, viruses, fungi, which plays a role in both health and disease. The lung microbiome consists of diverse bacteria, viruses, and fungi, which plays a role in both health and disease. Understanding pneumonia is crucial as it is the most common lower respiratory tract infection impacting morbidity and mortality rates. Key definitions and classification. Community-acquired pneumonia, CAP, occurs outside the medical setting in an immunocompetent host, with potential for multi-drug resistant pathogens in certain populations. Hospital-acquired pneumonia, HAP, diagnosed more than 48 hours after admission, including non-ventilator hospital-acquired pneumonia, which is NVHAP, and ventilator-associated pneumonia, which is VAP. Aspiration pneumonia is classified under CAP, highlighting the complexity of pneumonia classifications. Importance of understanding pneumonia types. Differentiating between CAP and HAP is essential for appropriate treatment and management strategies. Case study: a 72-year-old woman with diabetes presents pneumonia symptoms, illustrates the importance of classification based on hospitalization timing. The risk factor for pneumonia, including advanced age, chronic disease, and recent hospitalization. Pathogens and mechanism of pneumonia. Pathogenesis of pneumonia. Pneumonia pathogenesis involves host pathogens interaction through mechanisms such as aspiration, inhalation, and hematogenous dissemination. The lung microbiome's role in pneumonia development is an area of ongoing research emphasizing the need for a nuanced understanding of microbial interaction. Mechanisms for pneumonia development. It's aspiration, inhalation, contagious spread, or hematogenous dissemination. So aspiration, the most common mechanism where bacteria from the upper airway enters the lung, often due to anatomical connections between the gastrointestinal and respiratory tract. Inhalation is active inhalation of a pathogen like a virus, example COVID-19 or influenza, and Mycobacterium tuberculosis is a significant cause of CAP, which is CAP stands for Community-Acquired Pneumonia. Contagious spread. Pathogens can spread from adjacent infection, example, pleural or visceral infection, to the lung. Through this is less common. Hematogenous dissemination. Pathogens can reach the lung via the bloodstream, often the distant infection like endocarditis. Clinical manifestations and diagnosis. Clinical manifestations in pneumonia. A symptom includes fever, cough, confusion, respiratory distress with physical findings such as crackling, auscultation, palpitation, and radiograph opacities. Laboratory findings may show elevated white blood count, including infection. Diagnostic technique. A common diagnostic technique includes chest radiography, sputum cultures, and blood tests to identify pathogens and assess severity. Understanding the microbiological landscape is crucial for effective treatment planning. Treatment and prevention strategies. Empiric and specific antibiotic therapies. Treatment strategies depends on pneumonia type, CAP versus HAP, and the suspected pathogen involved. Empiric therapy often includes broad-spectrum antibiotics, while specific therapies target identified pathogens based on a culture result. Adjunction therapy and prevention. Adjunction therapy may include corticosteroids and supportive care to improve patient outcome. Prevention strategies. Prevention strategies often on vaccines, hygiene practices, and early identification of a at-risk population. The role of a respiratory therapist. Respiratory therapists play a crucial role in diagnosing and managing pneumonia, including administering therapy and monitoring patient progress. Their expertise is vital in optimizing care for patient respiratory infection. Hematogenous spread and microbiome alterations. Hematogenous spread in pneumonia. Hematogenous spread refers to dissemination of a pathogen through the bloodstream, which can occur in various conditions, including pneumonia. In acute respiratory distress syndrome, ARDS, bacteria can translocate from the portal circulation to pulmonary circulation, altering the lung microbiome. This alteration can lead to an overgrowth of pathogens that are normally present in the lower respiratory tract, such as Mycoplasma and Streptococcus species. The relationship between initial viral infection and subsequent bacterial co-infections is an area of active research, indicating a complex interplay in pneumonia development. Understanding these mechanisms is crucial for developing targeted therapy and prevention measures against pneumonia. Future research is needed to clarify the interaction between the microbiome and the pneumonia pathogenesis. Overgrowth of normal flora. The diversity of lung microbiome is essential for preventing overgrowth of pathogenic bacteria. An initial viral infection can disrupt the balance, leading to conditions favorable for bacterial pneumonia. The role for microaspiration, where small amounts of oral contents enter the respiratory tract, is highlighted as a common cause of pneumonia. The concept for normal flora, overgrowth, emphasizes the importance of maintaining a healthy microbiome to prevent infection. Case studies shows that patients with altered microbiomes are a higher risk of pneumonia, underscoring the need for microbiome research. Ongoing study aimed to explore the therapeutic potential of restoring microbiome diversity in pneumonia patients. Host defense mechanism against pathogens. Airway defense mechanism. The human body has several defense mechanisms in the upper and lower respiratory tract to combat pathogens, including mucociliary clearance and cough reflex. Anatomical features of the airway to help prevent widespread infection by localizing pathogens to specific areas. Local defense, including anatomical substances such as liposomes or lysozyme and lactoferrin defense or defensins, and immunoglobulin, example, secretory IgA and IgG. Local defense include antimicrobial substances such as lysozyme, lactoferrin, defensins, and immunoglobulin. Example is secretory IgA and IgG. Alveolar macrophages and epithelial cells play a crucial role in the innate immune system response at the alveoli level. Surfactant proteins are important for opsonization, enhancing the immune system's ability to engulf pathogens. These mechanisms work together to maintain microbiome balance and eliminate incoming pathogens. Innate and adaptive immune response. The innate immune system acts as the first line of defense, responding to pathogens in a non-specific manner when initial barriers fall. Cytokines such as TNF and IL-1 are released during the innate immune response, leading to fever and inflammation. The adaptive immune response is active when pathogens recognize receptors transporting antigens to lymph nodes where they are presented to lymphocytes. This response generates specific antibodies that targets pathogens, aiding in the resolution of infections. Vaccinations enhance both innate and adaptive response, providing protection against pneumonia. Comorbid conditions and diabetes can impair these immune response, increasing susceptibility to pneumonia. Clinical manifestation and diagnosis of pneumonia. Symptoms and signs of pneumonia. Common symptoms include fever, chills, cough, productive or non-productive coughs, dyspnea, and pleuritic chest pain. Non-pulmonary symptoms such as diarrhea, headache, and confusion may also occur, especially in elderly patients. Physical examination findings include dullness in percussion, increased tactical fremitus, and abnormal breathing sounds. Example, bronchial breath sounds, rales. Specific symptoms may suggest particular pathogens such as mycoplasma, pneumonia, associated with bolus myringitis, or skin rashes. The absence of vital sign abnormalities can significantly reduce the likelihood of pneumonia, indicating the need for imaging for confirmation. Image is essential to assess lung involvement and guide treatment decisions. Image findings in pneumonia. Classical imaging findings include alveoli field densities, air bronchograms, and ground glass opacifications. typically unilateral in bacteria pneumonia. Atypical or viral infections may present with diffuse, bilateral, interstitial infiltrated. In certain patients, initial image may be inclusive, necessitating following up image within 24 to 48 hours. Bilateral and multilobar infiltrates are indicative of several pneumonia presentations. Radiographic patterns are generally not useful for identifying the specific cause of pneumonia, such as CAP or HAP. Understanding imaging finding is crucial for accurate diagnosis and management of pneumonia. Image technique in pneumonia diagnosis. Overview of image modalities. Overview of image modalities. Image plays a crucial role in diagnosing pneumonia and its complications such as cavitary lung disease and pleural effusion. Common image techniques include chest X-ray, CT scans, thoracic ultrasound, each with unique advantages and limitations. Chest X-ray are often the first-line image tool, but may miss subtle findings, while CT scans provide better sensitivity for pulmonary infiltrates. Thoracic ultrasound is emerged as a valuable tool, especially in emergency settings, due to its ability to visualize the pleural effusion and lung consolidation. Cost effectiveness and radiation exposure are an important consideration when choosing image modalities. The choice of image technique can significantly impact diagnosis, treatment decision, and patient outcome. Specific imaging findings. Chest X-ray finding in pneumonia may include lobar consolidation, air bronchograms, and pleural effusion. CT scans reveal ground glass opacification, consolidation, and cavitary lesions, which are crucial for diagnosing complicated pneumonia. Ultrasounds can show dynamic air bronchograms and B lines indicating interstitial pneumonia, which are not visible on traditional X-rays. The presence of cavitary lesions may suggest specific pathogens such as tuberculosis or fungal infection. Imaging findings can guide the need for further interventions such as drainage for parapneumonic infusion. Understanding the image characteristics of different pathogens can lead in targeted treatment. Case studies and clinical examples. A case of lobar pneumonia caused by Streptococcus pneumoniae illustrates a typical presentation and image finding, including fever, cough, and chest pain. Pneumocystis jirovecii pneumonia, PJP, is characterized by interstitial infiltrates on X-rays and is common in immunocompromised patients, such as those with HIV. Invasive pulmonary aspergillosis present with cavitary nodules on CT, often in neutropenic patients, highlighting the importance of recognizing specific patterns. The use of ultrasound in diagnosing pneumonia is exemplified by its ability to visualize the pleural infusion and guide fluid samples. Each case emphasizes the need for a tailored approach to image based on patient's history and clinical presentation. These examples underscore the importance of integrating clinical findings with image results of accurate diagnosis. Epidemiology and impact of community-acquired pneumonia, CAP. Global burdens of CAP. CAP is the leading cause of morbidity and mortality worldwide, particularly in low-income countries with significant annual death rates. The World Health Organization identifies pneumonia as a major public health concern, especially among vulnerable populations such as the elderly, immunocompromised. Geographic variations in incidence are influenced by local pathogens, healthcare access, and socio-economic factors. Hospitalization rate for CAP can range from 10% to 60%, with a notable percentage acquiring intensive care. The economic burden for CAP is substantial, with ICU care costs significantly higher than ward care. Understanding the epidemiology of CAP is essential for public health strategies and resources allocation. Risk factor and comorbidities. Several comorbid conditions, including chronic lung disease, cardiovascular issue, and immunosuppression, including the risk of developing CAP. Prior respiratory infections such as influenza can predispose individuals to secondary bacterial infections. The presence of multiple risk factors can complicate the clinical picture and worsen outcome and CAP potential. Identifying at-risk population is crucial for preventative measures and early intervention strategies. The interplay between host factors and pathogen virulence can influence the severity of pneumonia. Public health initiatives should focus on vaccination, education to reduce the incidence of CAP in high-risk groups. Microbiology of a community-acquired pneumonia. Common pathogens. The most prevalent pathogen causing CAP include both viral and bacterial agents, with viruses often leading the initial infection. Streptococcus pneumoniae remains the most common bacterial cause of CAP, following by Streptococcus aureus and a typical pathogen like Mycoplasma pneumoniae. Viral co-infections are common, with respiratory viruses contributing to the overall burden of pneumonia. Emerging pathogens such as SARS-CoV-2, SARS-CoV-2 have highlighted the evolving landscape of CAP etiology. Understanding the microbiological profile of CAP is essential for guiding empirical antibiotic therapy. Mixed infections involving both typical and atypical pathogens are not uncommon and necessitate broad spectrum treatment. Yeah. Diagnostic challenges. Despite intensive testing, the causative pathogen is identified in only about 1/3 of CAP cases, complicating treatment decisions. ICU patients tend to have higher rates of pathogen identification due to more aggressive test protocols. The limitations for standard diagnostic methods underscore the need for improved techniques and rapid testing. Clinicians must consider the likelihood of various pathogens based on pathogen history and clinical presentation. The role for advanced molecular technique in identifying pathogens is becoming increasingly important. Ongoing research is needed to enhance diagnostic accuracy and treatment outcome in CAP. The overview of community-acquired pneumonia, CAP. Definition and importance of CAP. Community-acquired pneumonia, CAP, is an infection of the lung acquired outside the hospital setting, significant due to its prevalence and impact on public health. It is a leading cause of morbidity and mortality worldwide, particularly among vulnerable populations such as the elderly and those with comorbidities. Understanding the pathogens associated with CAP is crucial for effective diagnosis and treatment, as well as public health strategies. The most common pathogens include bacteria, viruses, and fungi, with varying prevalence based on geographic and demographic factors. Common pathogens in CAP is, viruses, bacteria, and fungi, but the virus is SARS-CoV-2, influenza, these are all viruses, influenza, AB, respiratory syncytial virus, RSV, rhinovirus, and adenovirus are prevalent viral pathogens. Bacteria is Streptococcus pneumoniae is the leading bacterial cause, with other significant bacteria including Staphylococcus aureus, Mycoplasma pneumoniae, and Legionella spp. Fungi. Less common pathogens include Coccidioides. As less pathogen comments in I don't know how to pronounce that word. How do you pronounce that word? Speak.
Coccidioides.
Coccidioides at SEP. Okay, so fungi less common pathogens include Coccidioides, the Histoplasma capsulatum, often associated with specific environmental exposure. Oh. Where was I? Innate, we talked about symptoms of pneumonia, overview of the specific images, case study. Global burden of CAP. What was the other thing? Case study. Specific image findings. Overview of morbidity. I forgot where I left off. Etymology. Oh, it's frozen. What did I read? I read something about CAP. Okay, CAP is leading cause of morbidity and mortality worldwide. Okay, the economic burden of CAP is substantial, with ICU care costs significantly higher than ward care. Understanding epidemiology of CAP is essential for public health strategies and source allocation. Risk factor of comorbidities. Several comorbidity conditions include chronic lung disease, cardiovascular issues, immunosuppression, increased risk of developing CAP. Prior respiratory infections such as influenza can predispose individuals to secondary bacterial infection. The presence of multiple risk factors can complicate the clinical picture and worsen outcome in CAP patients. Identifying a at-risk population is crucial for preventative measures and early intervention strategies. The interplay between host factors and pathogen virulence can influence the severity of pneumonia. Public health initiatives should focus on vaccines, education, and reduce the incidence of CAP in high-risk groups. Oh, I must have read that again. Microbiology of community-acquired pneumonia. Common pathogens. So the most prevalent pathogen causes CAP include both viral and bacterial agents and viruses from leading initial infection. Streptococcus pneumonia remains the most common bacteria cause of CAP, and followed by Streptococcus aureus and atypical pathogens like Mycoplasma pneumoniae. Viral co-infections are common, with respiratory viruses contributing to the overall burden of pneumonia. Emerging pathogens such as SARS-CoV-2 have highlighted the evolving landscape of CAP etiology. Understanding the microbiological profile of CAP is essential for guiding empirical antibiotic therapy. Oh, I've already read those several times. Mixed infections involve both typical and atypical pathogens are not uncommon and necessitated broad-spectrum treatment. Diagnostic challenges. We read that. Okay. So overall common community-acquired pneumonia, CAP. The definition of CAP is community-acquired pneumonia is an infection of lungs acquired in the hospital, significant due to prevalence and impact on public health. It is a leading cause of morbidity and mortality worldwide, particularly among vulnerable populations such as the elderly and those with comorbidities. Understanding the pathogens associated with CAP is crucial for effective diagnosis and treatment as well as for public strategies. The most common pathogen includes bacteria, viruses, and fungi, with varying prevalence based on genetic and demographic factors. So common pathogens in CAP are viruses, bacteria, and fungi. So the risk factors for CAP is common risk factors include chronic disease, asthma, diabetes, heart disease, immunosuppression, and lifestyle factors. smoking, alcoholism. Specific populations at higher risk include elderly and those with chronic lung diseases, and individuals with compromised immune systems. Understanding these risk factors can help identify at-risk patients and tailoring preventative measures. Definition and importance. Community-acquired pneumonia, CAP, is the infection of the lung acquired outside the hospital setting, leading to a significant morbidity and mortality. It is crucial to identify CAP early to initiate appropriate treatment and improve patient outcome. CAP can be caused by various pathogens, including bacteria, viruses, fungi, with viral infections becoming more prevalent, especially during pandemic like COVID-19. Biomarkers in CAP diagnosis. Biomarkers such as procalcitonin, I don't pronounce that.
Procalcitonin.
Procalcitonin, PCT, can help clinicians determine the need for antibiotics and reduce unnecessary use, thus combating antibiotic resistance. Evaluated biomarkers during the acute phase. Ouch. Where am I? Evaluating biomarkers during the acute phase of the disease can indicate the severity of the infection and guide hospitalization decisions. Clinical guidelines suggest that biomarkers should be used in conjunction with other clinical parameters or for accurate diagnosis. Case study analysis. A 43-year-old patient with symptoms indicative of pneumonia was diagnosed with a viral infection like SARS-CoV-2 based on clinical findings, laboratory results. Key indicator includes elevated C-reactive proteins, lymphopenia, and bilateral interstitial infiltrates on chest radiography, which characteristics of viral pneumonia. The importance of supplemental oxygen, antiviral, and corticosteroids in managing COVID-19 pneumonia is highlighted. Pathogens associated with community-acquired pneumonia. Common viruses are SARS-CoV-2, influenza A/B, and respiratory syncytial virus, RSV. Can you speak that?
Syncytial.
Syncytial virus, RSV. So SARS-CoV-2 is the virus responsible for COVID-19, leading to a severe respiratory illness, particularly in older adults and those with comorbidities. Influenza A/B, seasonal viruses that can cause significant respiratory illnesses, especially in winter months. Respiratory syncytial virus, RSV, common in children and can lead to several respiratory infections in infants and elderly. So common bacterias are Streptococcus pneumoniae, Staphylococcus aureus, Mycoplasma pneumoniae. So Streptococcal pneumoniae, the most common bacterial cause of CAP, known for its potential to develop drug resistance, DRSP. So develop drug resistance, DRSP. Staphylococcus aureus, including methicillin resistant Staphylococcus aureus, which is MRSA, associated with severe pneumonia cases, especially in post-influenza. Mycoplasma pneumoniae is atypical bacteria that often causes milder pneumonia, particularly in younger populations. Less common pathogen is Legionella SPP, associated with outbreak, particularly in humid environments or water system, or Coxiella burnetii cases causes acute fever, often linked to exposure to farm animals. Let's see how I pronounce it.
Coxiella burnetii.
Coxiella burnetii causes acute fever, often linking to exposure to farm animals. Chlamydophila piscicii, I can't even pronounce that.
Chlamydophila psittaci.
Chlamydophila psittaci, associated exposure to bird, leading to atypical pneumonia. Laboratory diagnosis of CAP. Diagnostic testing is a CBC, complete blood count, used to assess leukopenia or leukocytosis, which can indicate a bacterial infection. Blood cultures recommended for patients requiring ICU admission or with severe symptoms to identify causative organisms. Sputum, gram, stain, and culture helps differentiate between colonization and infection, guiding antibiotic therapy. Biomarkers in CAP. C-reactive proteins, CRP, and procalcitonin, PCT. C-reactive protein, how do I pronounce this one? Biomarkers in CAP.
Procalcitonin.
Procalcitonin. So, C-reactive protein, CRP, and procalcitonin, PCT, elevated levels can indicate a bacterial infection and help guide antibiotic therapy duration. Liver enzymes elevation can indicate viral infection or atypical pathogen, aiding in diagnosis. Arterial blood gas, ABG, is used to assess oxygenation and acid-base status, critical in severe cases. Advanced diagnostic techniques are polymerase chain reaction, PCR, a rapid molecular testing that increases the pathogen identification accuracy, especially for viral and atypical pathogens. Urinary antigen tests, specific for pathogens like Legionella and Streptococcus pneumoniae, or providing quick results for targeted treatment. Bronchoscopic sampling, more invasive but can yield better diagnostic results in severe cases requiring mechanical ventilation. Clinical case study. Patient presentation. A 43-year-old patient presents with a malaise. Presenting malaise, fever, cough, and shortness of breath, indicating possible CAP. Physical examination reveals a tachycardia, tachypnea, and bilateral crackling, common signs of pneumonia. Chest radiograph shows bilateral interstitial infiltrates, suggesting an infectious process. Laboratory findings. White blood cell count of 3,000 mm³ with lymphopenia indicates a viral infection, while elevated CRP suggests inflammation. What is CRP again? CRP is C-reactive protein. So the laboratory findings, while elevated CRP suggests inflammation, white blood count of 3,000 mm with lymphopenia indicates viral infection. Normal procalciton levels. Oh, I can't pronounce that. Normal
Procalcitonin.
procalcitonin levels may indicate a viral rather than a bacterial cause, guiding treatment decisions. Arterial blood gas shows hypoxemia, necessitating further evaluation and potential hospitalization. The diagnostic approach. Blood culture, sputum gram stain, and viral respiratory panel are collected to identify the causative pathogen. The presence of a specific biomarker and image finding will guide the treatment plan and hospitalization needs. Understanding the patient's risk factor and the clinical presentation is crucial for effective management. Site of care decision making. Site of care decision making. Important of site of care decisions. The site of care, hospital ward versus ICU, significantly impacts patients' management and outcome in CAP cases. Tools like Pneumonia Severity Index, the PSI, and the CURB-65 score helps clinicians assess severity of pneumonia and make informed decisions about hospitalization. CURB-65 is similar, using only 5 variables, while PSI is more comprehensive, requiring 20 variables or assessments. CURB-65 and PSI scoring system. CURB-65 includes criteria such as confusion, urea levels, respiratory rate, blood pressure, and age, with a score of 2 or more indicating severe pneumonia. The PSI score assessment varies factors including age, comorbidity, and clinical findings to stratify risk and guide treatment. Both scoring systems aim to identify patients who can be safely discharged or require hospitalization. Case study, site of care determination. A 74-year-old patient with a multiple comorbidity and severity symptom was assessed using CURB-65 scoring 5, indicating need for hospitalization. The patient also met several minor criteria from the IDSA/ATS guidelines suggesting severe CAP and high-risk clinical deterioration. The appropriate site for care for this patient was determined to be the ICU due to the severity of their condition. Therapeutic approaches in CAP management. Initial therapy recommendations. Early initiation of antimicrobial within 4 hours of presentation is crucial for hospitalization patients with CAP. Treatment should be tailored based on the severity of the disease, likely pathogens, and individual risk factors. Combination therapy is recommended by several CAP to cover both typical and atypical pathogen effectiveness. Antimicrobial stewardship. Narrowing of antibiotics occur as soon as the microbiological diagnosis is established to minimize Resistance duration of therapy is typically 5 to 7 days, with shorter courses 3 days for mild to moderate cases achieving clinical stability. Individual treatment plans are necessary for patients with complicated infections or those for responding to initial therapy. Summary of therapeutic guidelines. The therapeutic approach should be guided by a severity of CAP, with specific recommendations for different risk factors and pathogen types. Empirical anti-pseudomonal therapy is indicated for patients with risk factors for Pseudomonas infection. Contagious assessments and adjustments of the therapy based on the clinical responsibles and laboratory results as essential for optimal patient outcome. Pneumonia Severity Index and CURB-65 risk stratification. The Pneumonia Severity Index, PSI, is a tool used to assess severity of pneumonia and guide treatment decision. It is considered factors such as age, comorbidity, and vital signs to assist a score that correlates with mortality risks. The PSI score is categorized in 5 risk classes, with Class 1 indicating the lowest risk and Class 5 the highest, guiding the recommended site of care. Recommended site of care. For example, classes score has a morbidity rate of 0.1% and recommended outpatient care, while Class V scores 100, scores greater than 130, has mortality rate of 29.2% and requires inpatient care. The 3 steps process for determining the initial site of care includes assessing pre-existing conditions, calculating the PSI score, and the ability clinical judgment. The CURB-65 score is another tool that assesses pneumonia severity based on confusion, urea, respiratory rate, blood pressure, and the age greater than 65 within higher score indicates increased mortality risks and need for inpatient care. Both PSI and CURB-65 scores are essential for stratifying patients and engulfing appropriate treatment settings. So CURB-65 is a clinical prediction rule that helps determine the need for hospitalization in patients with pneumonia. It is designed pointed based on 5 criteria: confusion, urea level, respiratory rate, blood pressure, and age. Each criterion score each criterion score 1 points with a total score of 0 to 5, indicating the severity of pneumonia and corresponding mortality risks. A CURB-65 score of 0 to 1 suggests outpatient treatment, while scoring of 2 to 5 indicates increasing need for inpatient care, with score of 4 to 5 suggests possible ICU admission. The mortality rate associated with CURB-65 are significant, with a score of 0 having a mortality rate of 0.1% and a score of 5 having a mortality rate of 40 to 57%. The CURB-65 score is particularly useful in emergency settings to quickly assess the severity of pneumonia, make timely decisions regarding patient management. Understanding both PSI and CURB-65 allows healthcare providers to tailor treatment plans effectively. ICU level care. Major and minor criteria for ICU admission. The need for ICU admission in pneumonia patient is determined by specific criteria categorization into major and minor criteria. Major criteria includes the need for mechanical ventilation, which indicates severe respiratory failure and septic shock requiring vasopressors and reflecting critical illness. Minor criteria includes elevated respiratory rate of 30 breaths per minute, greater than 30 breaths, greater than to equal to 30 breaths per minute. Leukopenia, confusion, and hypothermia, among others, with at least one major or 3 minor criteria indicates severe pneumonia. The presence of multilobar infiltrates on imaging can also suggest a more severe disease process, necessitating closer monitoring and potential ICU care. These criteria help clinicians identify a patient at high risk for deterioration and ensure they receive appropriate intensive monitoring and treatment. The guidelines emphasizes the importance for early recognition of severe pneumonia to improve patient outcome. Antibiotic therapy for community-acquired pneumonia. CAP. Non-severe CAP treatment guidelines. Non-severe CAP is typically treated with empiric antibiotics targeting common pathogens such as Streptococcus pneumoniae and Haemophilus influenzae. Let's see.
Haemophilus influenzae.
Haemophilus influenzae. Recommended empiric therapy includes a beta-lactam, example, cefotaxime or cetirizine. God, I haven't pronounced these names.
Cefotaxime, ceftriaxone.
Cefotaxime, ceftriaxone, combined with a macrolide, example, azithromycin, or respiratory
fluoroquinolone.
Fluoroquinolone, example, levofloxacin. The choice of antibiotics may vary based on the local resistant pattern and patient-specific factors such as allergies and comorbidities. The guidelines recommended reassessing therapy based on clinical response and microbiological data, adjusting a necessary for resistant organism. Early initiation of appropriate antibiotics is crucial for improving outcome in patients with CAP. The management of CAP should also consider the patient's overall clinical picture, including comorbidities and severity of illness. Severe CAP treatment guidelines. Let me see how much more to read. Oh, it's a lot. Almost there. So we're at severe CAP guidelines. Severe CAP guidelines. Severe CAP requires more aggressive treatment, often necessitating intravenous antibiotics and potential hospitalization. Empiric therapies for severe CAP includes intravenous beta-lactams combined with a macrolide or a respiratory fluoroquinolone targeting a broader range of pathogens. In cases where MRSA or Pseudomonas aeruginosa is suspected, additional covering with vancomycin or linezolid, linezolid, and anti-pseudomonial beta-lactam is recommended.
Anti-pseudomonal beta-lactams.
Is recommended. So the guidelines emphasize the importance of adjusting therapy based on culture results and clinical response to ensure effective treatment. Patients with severe CAP may also require adjunctive therapies such as corticosteroids, particularly in cases of severe viral pneumonia. Continuous elevations of the patient's response to treatment is essential for optimizing care. The adjunctive therapy and supportive care. The role of corticosteroids in respiratory support. Corticosteroids are of interest in managing severe CAP, particularly in COVID-19 cases, but are not recommended for other viral pneumonias due to potential harm. The use of corticosteroids in patients with
Cerevisiae pneumonia.
P. cerevisiae pneumonia can be beneficial if initial arterial oxygen tension is low, helping to reduce inflammation. Respiratory support is critical for patients with severe CAP. Options including non-invasive positive pressure ventilation and high-flow nasal cannula. An invasive mechanical ventilation should be avoided when possible to reduce risks such as ventilator-induced lung injury and prolonged ICU stay. The choice of respiratory support method depends on the severity of hypoxemia and underlying case of respiratory failure. Continuous monitoring and adjustment of respiratory support are vital to ensure patient safety and comfort. Oxygen delivery device. Low-flow nasal cannula. Delivers dry oxygen at flow rate of 1 to 6 liters a minute through small prongs placed in the nares, suitable for patients requiring low levels of oxygen. Commonly used in outpatient settings and for patients with mild respiratory distress. Advantages include comfort, ease, and use, allowing patients to speak and eat while receiving oxygen. So that's a low-flow nasal cannula. Non-rebreather mask and Venture mask. Non-rebreather mask can deliver oxygen at flow rate of 5 to 15 liters per minute, providing higher concentration of oxygen for patients in acute distress. Venturi masks are designated for patients with conditions like COPD, delivering precise oxygen concentration, 24 to 60%, at a flow rate of 2 to 5 liters per minute, crucial for managing hypercapnia.
Hypercarbia.
Okay, hypercarbia. The venture mass ability to control oxygen level makes it essential for patients needing strict oxygen management. Non-invasive ventilation, NIV. Non-invasive ventilation, NIV, is beneficial for patients with conditions like cardiogenic pulmonary edema or acute exacerbation of COPD, providing respiratory support without intubation. Studies indicate that NIV, non-invasive ventilation, can improve outcome in specific patients' populations, but it has limitations such as discomfort, gastric distension, and then delaying intubation in patients requiring invasive mechanical ventilation can lead to the worst outcome. High flow nasal cannula, HFNC. High flow nasal cannula delivers blended humidifier care and oxygen at a high flow rate, improving patient comfort and oxygenation, particularly effective in patients with community-acquired pneumonia, especially those with COVID-19, reducing the need for invasive ventilation. High-flow nasal cannula is emerging as preferred alternatives to NIV in certain clinical scenarios. What is NIV again? I said NIV is non-invasive ventilation. Management of severe community-acquired pneumonia. Ventilation strategies. For a patient with severe CAP requires mechanical ventilation, a low tidal volume strategy, 6 milliliters per kilogram PBW is recommended to minimize lung injury. Positive end expiratory pressure, PEEP, is also utilized to improve oxygenation and prevent atelectasis. Prone positioning has been shown to enhance survival rates in patients with severe acute respiratory distress syndrome, ARDS, particularly those with a low FiO2 requirement. Extracorporeal member oxygenation, ECMO. Extracorporeal member is considered a salvage therapy for severe pneumonia cases, including H1N1, despite its associated risks and prolonged ICU stay. The effectiveness of extracorporeal membrane oxygenation in severe CAP remains debated, but registry reviews suggest better outcome for pneumonia patients compared to other conditions. The decision to initiate extracorporeal membrane oxygenation should be based on individual patient assessment and potential benefits versus risks. Preventative strategies. Immunization against pathogens like pneumococcus,
Pneumococcus.
Immunization against pathogens like pneumococcus, influenza, and SARS-CoV-2 is crucial in preventing CAP. Okay. Annual influenza vaccine is recommended for everyone aged 6 months and older, while pneumococcal vaccines are advised for specific high-risk groups. COVID-19 vaccines available in the U.S. includes mRNA vaccine, protein subunit vaccine, and viral vector vaccines, all recommended for individual 6 months and older. Hospital-acquired pneumonia, HAP, and ventilator-associated pneumonia, VAP.